you all. So as ma'am said, today we are going to learn about subcutaneous infusion. I know as the nurses, we are familiar with the subcutaneous injections, not in subcutaneous infusions, but in palliative care, this is the method which we have used, commonly used in patients. We have today we have Sajan. Sajan is a nurse, BSc nurse. He has more than 8 years of experience in palliative care. Now he is working as a section head in inpatient. We have an inpatient settings. He is working as a session head in that department in the inpatient department. So welcome Sajan and over to you.
Good afternoon to all. Once again, I'm introducing. I'm Sajan. Today, I will like to discuss about the subcutaneous infusion with you. First of all, before going to the directly to the subject, just we can go through the layers of skin. Just introducing as a simple manner, 3 layers. First one, dermis layer. Second one, subcutaneous layer. Third one, muscle layer. In the subcutaneous layer, we introducing the injection to the patient. For this subcutaneous layer, we are going to discuss about subcutaneous infusion. That term we can use hypodermolysis. That also. What do you mean by subcutaneous infusion or hypodermolysis? Any idea? We can just split the word.
I think so. You can put your answer in the chat box. So, what do you understand about subcutaneous infusion or hypodermolysis? Anybody? Any answers?
We can inject some medications to absorb more slowly than IV.
Okay. Any other answers?
So it is also called as interstitial infusion.
Okay.
Hello.
Yes, yes.
Yeah, it's been mainly used for dehydration.
Okay.
So kind of subcutaneous route of administration, fluids to the body.
Okay. Thank you.
We can just split the word hypodermolysis into 3. First one, hypo. Hypo means below. Below the dermis layer. Lysis means administration. So we can explain as administration of bolus injection or fluid below the level of dermis layer. That means subcutaneous layer. That is the subcutaneous infusion or hypodermolysis. It's large volume and large volume. Small volume means Any bolus injection we need to give to subcutaneously, we can give. And large volume means mild to moderate dehydration. In that case, for the rehydration, any fluid we can give. If needed, we can give by subcutaneously. As we all know, we are mainly having two types of routes of administration. Which are they? Mainly two types of routes of administration are there. Simply we can say parenteral route of administration and non-parenteral route of administration. Non-parenteral route means by pricking a needle. We are administering means parenteral route, and non-parenteral route means example. Anybody can say example for non-parenteral routes of administration?
He is asking non-parental route of administration example. So tell me the few examples of non-parental route of administrations. Anybody oral? Okay, Nirosha said oral. Any other answers? Non-parental route.
It's sublingual, rectal,
Rectal, very good.
sublingual,
Okay, good.
aerosol, buccal, and intranasal. All these are non-parenteral routes.
Okay, okay, thank you.
Already you answered a lot. Oral route, rectal route, or sublingual. These are all the main examples for the non-parenteral routes of administration. If we discussing about parenteral route means by pricking a needle, we administering the injections to the tissues. In that parenteral route, one of the route is subcutaneous route. For the subcutaneous route, we going to discuss. Mainly in palliative care, we mainly giving importance for the subcutaneous routes for the administration of medication. What are all the indications? Mainly, somebody is already given answer like for the dehydration, we can use subcutaneous route. It's absolutely correct. But mild to moderate dehydrated, one patient is having mild to moderate dehydration means for the rehydration, we can use subcutaneous route for the rehydration. Then if the patient having dysphagia or swallowing difficulty, patient is having the pain while swallowing, that condition also we cannot give by orally. That time we can give by subcutaneously injections. Then if one patient needs fluid less than 3 liters per day within 24 hours, maximum 3 liters if the patient need to give by as like infusion, we can give by subcutaneously. Then mainly in palliative care, I already told in palliative care as a parenteral route, we mainly giving importance for the subcutaneous route for the administration. First one, if the patient having severe nausea and vomiting, such a condition, we cannot give any medications by orally because due to the nausea and vomiting. For the symptomatic management, we can give the injection form by subcutaneously. Along with that, due to the nausea and vomiting, if the patient having mild to moderate dehydration also, we can rehydrate by subcutaneously. Along with that, if the patient having esophageal lesion or inside the mouth or throat area, any ulcer formation is there. In such condition also, patient due to the pain or swallowing difficulty due to the burning sensation, patient cannot take anything by orally, as like food item or any oral form medications also, as like syrup or tab form. Nothing that patient can take by orally due to the such conditions. That condition also for the symptomatic management, any medicine we need to give for the patient means we can give by subcutaneously. Then mainly in GI related cancerous condition, at the stage of progression, we can expect the intestinal obstruction also according to the disease condition or by the metastasis. Intestinal obstruction we can expect. That condition also we continuously given oral form of medications for his symptomatic management. It's totally inappropriate because already having the intestinal obstruction, it will not appropriate for such a situation. That condition also, anything injection form we need to give means by we can give by subcutaneously. Then if the patient is unconscious, I'm not telling about unconscious patient in mainly in ICU setting. In our palliative care setting, due to the progression of disease or as like end of life, patient is totally unconscious. For just as a maintenance or for just keeping the quality of patient life, if anything we need to give for the symptomatic management. If the patient is having pain, but due to the unconscious level, patient is not responding, if the patient is having pain or not. So in such conditions, we can give injection form of medicines only. We can give by subcutaneously according to the rate. Then if the patient having severe pain, that means example as a score we can say like 10 by 10 or 9 by 10 pain score. Patient is crying a lot due to the pain. Patient is very much distressed and irritant also. In such condition, if we are giving tab form of morphine or tab form of any pain medicine, that means it's totally inappropriate because so much time needs for the action by a tab form or syrup form. In such condition also, for the fast relief, we need to give injection form. In one example also, if the patient is highly delirious or highly restlessness, if the patient is having, if we giving any tab form of haloperidol or anything means, it will not help him for making rest as soon. In such condition also, we can give injection form of medicine. That is the intractable symptom. In such situations, that symptom we can manage by only by using injection forms. We can give by subcutaneously. Then already we discussed in non-parental route, along with the oral route, rectal route also we can use for giving the medications. But if the patient is having spurious diarrhea or contraindicated case like having hemorrhage, or if the patient is not willing to take medicine by rectally, because example is the patient is having shyness, such conditions we cannot compel or we cannot give anything by rectally. In such condition also, we can give injection form of medication by subcutaneously. Then we moving to the sites of subcutaneous injection. Can anybody say some examples for the sites of subcutaneous injection? At least 2 to 4 sites. Okay, thighs. Then
upper arms, you can give an arms, outer area of arms.
okay, right.
Then You can give in like buttocks, outer area of buttocks.
Okay.
You can give in hip, upper part of the hip, and abdomen. Abdomen
Okay.
also, it is it's like 2 inches around the navel. That also can be subcutaneous route.
Okay. Thank you, ma'am. Mainly, first one is upper chest region. Upper chest or intercostal plane. Mainly, if we giving injection to this area, if the female patient means we need to avoid the breast tissues. We need to ensure it's a upper chest level only. Next one, upper arm or outer aspect or lateral aspect of upper arm, both upper arm. Then outer thigh or lateral aspect of both thigh region. Then upper back, upper buttocks region. Then scapular area. Scapular area and one more area is there, umbilicus, around the umbilical area. These are all the main sites we can give subcutaneous injections. Mainly in our home care setting or in our palliative care setting, mainly we using both upper and lower arm, lateral aspect or outer aspect. We mainly choosing these areas because in home care setting we can teach the caregiver for giving subcutaneous injection. So these areas more confident for the caregiver also. Along with that, if these areas is inappropriate for giving the injection means we can choose the upper chest area, scapular area, and buttocks region. These are all the areas we cannot give subcutaneous injections. First one, lymphadenmatous area. If the patient is affected with CA right or left, along with that, that side affected with lymphedema also. If we noticing that we cannot give the subcutaneous injection on that arm, we need to avoid. Then, if the patient having skin sites having recently irradiated skin, any sign we noticing means we cannot give that area. Then bony prominence. Then nearest area to the joint region we cannot give. Then if patient is severely obese means skin folds we can see. In skin folds region also we cannot give subcutaneous because we cannot ensure the injection is totally going to subcutaneous or to deep or superficial. We cannot ensure, so we need to avoid the skin folding areas. Then already that area having inflammation or infection sign is there means also we need to avoid. Then if we giving injection to the around the umbilical region, already the patient having ascites means we need to avoid. We cannot give that ascites case around the umbilical region, we cannot give. Then as like lymphedema, if the patient having pitting edema on lower limbs means we need to avoid that arm for the subcutaneous injection. Then any area having tumor or any scar mark means we need to avoid. We cannot give that area subcutaneous injections. Then can anybody say some examples for the medications we can give by subcutaneously? Anybody?
So what are the medications which we can given subcutaneously? Insulin, okay. One of you said insulin. Then any other answers?
Vaccines.
Vaccines. Okay. Opioids. Epinephrine. Okay. Thank you.
Some of the examples for the subcutaneous medications. First one, injection morphine, then injection haloperidol, injection midazolam, injection metoclopramide or injection pyridinone, injection hyoscine butyl bromide or injection buscopan, injection fentanyl. These are all the main examples for the subcutaneous injections. Studies are going on. Some more medications we can give by subcutaneously. Mainly, we practicing these medicines in our palliative care setting. Then these are all the category medicines we cannot give by subcutaneously. First one, injection Stemetil, injection diazepam, then antibiotics, injection chlorpromazine. These are all the category medicines we cannot give by subcutaneously. Concentrated and oily medicines mainly we cannot give by subcutaneously. It will not help to absorb by the subcutaneous tissues. It will cause the tissue damage. So we need to avoid such medicines. Then procedure. As like every procedure for the subcutaneous introduction also, we need to explain about the procedure to the patient and the family. Because mainly in my experience, in palliative care setting, first of all, if the patient is coming in our palliative care setting, means subcutaneous route of administration is totally unaware for the patient and the caregiver. In their knowledge, mainly in injection form of medicine means intravenously or intramuscularly. They were well aware about the type of injection, but by a subcutaneous route of injection and infusion is totally unknown for them. So we need to explain the procedure to the patient and family. Then wash hands, hand washing is must. Then assemble fluid and tubings. Which fluid we need to give, which medicine we need to give. We need to assemble that fluid and tubing. Then we need to choose the area. After choosing the area, we need to clean that area by using antiseptic solutions of the swab, by using a circular motion from center to outward of that selected area. Then leave to dry for maximum 2 minutes. After cleaning, after cleaning the area, never touch again that with bare hands. Then insert the needle. Mainly we using scratch vein set or SV set or butterfly cannula. We using for inserting as a needle. We need to ensure the bevel up. Bevel up means that area as like a cross section on the tip of the needle. That bevel up region of upright position we need to maintain. Then insert the needle on the selected clean subcutaneous area, that tissue at 30 to 45 degree of angle. That degree of angle we need to prick the area. Then after pricking and completely inserting the needle to the subcutaneous tissue, we need to secure that scalp vein set or butterfly cannula on that body part by using on occlusive dressing or adhesive dressing. Then we need to just notice the date and the time. As like IV cannulation, we need to do. Periodic monitoring we need to do. So we need to write the date and the time on the area. Then adjust the rate of fluid as per the prescribed dose and rate.
Okay, now we can watch a video on how to put a subcutaneous infusion. And
Thank you. Next, we moving to the volume and rate of subcutaneous infusion. Mainly, as we know, 1 ml per minute. That 1 ml means 20 drops. That is the maximum speed we can, or maximum rate we can give in 1 minute. 1 ml or 20 drops we can give subcutaneously. In one side, within 24 hours, maximum 1.5 liter or 3 pint of fluid we can give at a one side within 24 hours. As like maximum 2 sides we can choose. For 2 sides, maximum 3 liter or 6 pints of fluid we can give maximum within 24 hours. Maximum 2 sides only we can give maximum 3 liter. Then, as like every procedure, after the procedure, we need to ensure, first of all, after the starting of infusion subcutaneously, within 2 hours, never cross 1 liter. Within 1 liter only, we need to give within 2 hours. Then document the name of medication and the rate in the medication chart. As per the prescription only, we need to set the rate. So we need to document. Then after starting the infusion, we need to check the patient. After 1 hour, strictly we need to ensure that area having that area is correct, or any signs of edema or any fluid leakage on that area. Within 1 hour, we need to strictly ensure about that area. Then, if necessary, if the area having so much edema we are feeling means mild massage we can give for the edema absorption. If again edema is not, just we noticing that edema on that area, or patient is having any distress, we need to change the area, or otherwise mild edema is helpful for the edema absorption. Then what are all the advantages for the subcutaneous injection? Can anybody? Some of the advantages of subcutaneous injection.
so we are talking about subcutaneous infusions. He's asking what are the advantages of subcutaneous infusion or continuous infusion. Any answers? So one of you said diffused very slowly. Any other answers? Okay. Slow action to the body. So, and one answer, easy to manage and attend. Very good. Easier than IV. Okay.
First one, it's low cost only because already I told we mainly using butterfly cannula or as we said we using for as a placing as a needle. Comparatively with IV cannulation on cannula, this FC set is comparatively low cost, and that accessory items also comparatively low cost only. Then more comfortable than IV administration for the patient and for the staff also. If on IV administration means maximum either more supervision needed or more experience needed for the IV cannulation. But in subcutaneous routes, subcutaneous infusion, that means little or limited supervision or limited experienced fellow also, we can introduce the subcutaneous needle. For the home care setting also, we can teach the caregiver for the subcutaneous introduction or subcutaneous infusion. So it's comfortable than IV administration subcutaneously. Then if we anything fluid by IV administration means it may cause pulmonary edema or fluid overload for the patient. But subcutaneously, it's not directly involving to the circulatory system. So it's not at all cause any pulmonary edema or any fluid overload. If anything means cause means also that area little bit edematous, that much only. So it's less likely than IV administration to cause pulmonary edema or fluid overload. Then simple insertion, it will not cause any distressing for the patient comparatively with IV. Easier reinsertion also, because for the IV cannulation, we need to tightly hold the area for getting the patency. After that only we can prick by using IV cannula. These are all the procedure will make distress for the patient. But in subcutaneous, we cannot, we don't want anything this much preparation. We can just simply select the area, just hold the area, prick the needle and fix the needle on the body surface. That much only. So simple insertion technique for the patient also. Then reinsertion also very much easier. If IV cannulation, patency losing means we need to change the cannula. Again, already told the procedures we need to repeat for the reinsertion. But subcutaneously, if we need to change the area means we can reinsert the subcutaneously easier than the IV route. Then for IV line in home care setting also, if the caregiver is much experienced or caregiver having the experience in our profession, that only they can give they can use IV line, or any staff supervision also needed. But subcutaneously, common people can prick the by subcutaneously and give injection by subcutaneously. Does not cause any thrombophlebitis, mainly seen as like in IV cannulation. Then it's not at all directly involving to the circulatory system. So as like in IV route, cause any septicemia or systemic infection. In subcutaneous route, it will not cause as like septicemia or systemic infection. Then if any bolus injection we giving intravenously, example, today morning we given on bolus of injection. Next on bolus we need to give on next day or after 20 hours, after 24 hours. We will cause the losing the patency of IV cannula or cannula became blocked. So we cannot again give by intravenously. But in subcutaneous route, such difficulties will not arise because it's not at all directly involving to the bloodstream. So no clot formation in the subcu site or subcu needle. So at any time we can restart or stop the infusion and injection by the subcutaneously. It's one of the main importance and it's easy to give. Then this clot formation or any bloodstream, just we are feeling in the SV lining means we need to change the side. Normally it will not occur. Anything we noticing means we need to change the side. Then as like advantages, some minor disadvantages also there. In some situations, inflammation on that pricking area or infusion site, possibility for the irritation or inflammation in some cases. Then some cases, possible leakage problem also on the subcutaneous site. If that subcutaneous site much more absorption is not there means it's possibility for the leakage on that site. This is the second disadvantage. Then if the patient having the allergic reaction, example, that occlusive dressing or adhesive tape, that material is allergic for some patients. In such situation also, that's also very much rare only. Allergic reaction also may will cause by using these accessory items. Then some side effects or complications just listing out. First one, localized edema. First of all, we need to explain to the caregivers some localized edema, mild edema is normal only if it's sustained after some time, but it will not completely or it may cause much more edematous. Just feeling means we need to give the explanations. Usually it will resolve spontaneously or with mild massage we can subside the localized edema. If much more edema just feeling means only we need to change the area, we can expect the poor absorption on that area. Then inflammation or cellulitis. Mainly aseptic technique we following. If we follow any poor aseptic technique means it will cause the inflammation or cellulitis. After cleaning the area, again we touching that area with bare hands or with any other item. Then we pricking the area by using needle means in such conditions of poor aseptic technique may will cause inflammation or cellulitis. We need to ensure about that. Then if the patient having pain or discomfort on the insertion site, mainly it's also rare. Already we told the rate of infusion, rate of injection. Bolus injection or infusion means 1 ml per minute or 20 drops per minute. If the rate is increasing means much more volume of fluid introducing to the subcutaneous tissue at a time. In such condition, patient will feel the pain or discomfort on the insertion site. We need to reduce the infusion rate. It will resolve the problem. Then normally 30 to 45 degree angle, we pricking the SV set or butterfly cannula on that area and placing. It will not prick the capillaries or any bloodstream. Never we can see any tinged blood stream on the tubings. But in rare cases, it will occur. In such conditions, we need to resite. We need to remove and resite the subcutaneous. Then insertion site having any hematoma, it's also very rare. If the patient associated with any low platelet level or patient is already on the anticoagulant therapy taking, in such conditions, hematoma around the insertion site will we can notice. It's also very much rare only. Then infusion device occlusion, very rare only because externally connecting tubing with the butterfly cannula and infusion fluid, if we using the IV set, tingling on the external tubing, it will cause this problem. It's also very rare. We need to ensure about that. Then what are all the nurses' responsibilities? As like every procedure after doing, as a nurse, we are having some responsibilities. Inspect the site every 4th hourly. Every 4th hourly, we need to inspect the site. First one, if the area having tenderness or hardness on that site, we need to inspect and we need to ensure about that. Then any presence of hematoma, then leakage at the insertion site, any leakage, then local tissue irritation, then redness on that area, or any presence of blood in the tubing. Then in some situations, displacement of the cannula also may will occur, because by the accidentally it will displace the cannula. In these conditions, we need to inspect every 4th hourly. In any such situations, we noticing means we need to change the site and the resite for the subcutaneous injection. Then we moving to the just telling about the syringe driver. Syringe driver is a small portable by using with battery driver infusion pump, mainly using for the medication intravenously and subcutaneously for the around 24-hour, every hour to 24-hour continuous infusion. If any patient need means with intravenously or by subcutaneously, we can use this syringe driver. In our practice, syringe driver is mainly we using for giving continuous infusion. This one is the model of syringe driver. This syringe driver, 1 hour setting syringe driver. For this syringe driver, we can give the subcutaneous infusion or intravenous infusion minimum 1 hour to maximum 24 hours we can give by using this syringe driver. In one more model is also there, 24 hour, minimum 24 hour to maximum according to the rate. That one minimum 24 hour, this one is maximum 24 hour. In my practice, in our setting, this syringe driver is commonly used. This syringe driver has one benefit, mainly I can say, not at all in hospital, in home care setting also we can use this syringe driver. In case of syringe pump, we cannot give it to the home setting. This one is the first benefit of the syringe driver. These are all the parts of a syringe driver. Okay, thank you.
Thank you, Sajan, for the presentation. Anybody have any doubts regarding the subcutaneous infusion? Please ask him. Anybody? So please put on your video. Okay. So any doubts? Do you have any experience in subcutaneous infusion in your settings? Do you have any experience? Anybody? No. Okay. So one of you said have never done. Can you think this is the suitable for that way for infusion? So, okay, thank you. If you don't have any experience, definitely you have a lot of doubts. The subcutaneous infusion, you don't have such experience, no? Please,
Excuse me, ma'am.
yes.
I don't have experience with this type of infusion administration. So, can you please tell me in your setting, do you practice that practicing this in a home care setting? That means, if are you sending patient with this infusion to the home
Yes.
normally?
Yeah. So thank you, Nirosha. Usually we put the subcutaneous infusion, that cannula, and send the patient. If the patient wants to go home, we send them back to where in the subcutaneous the site is already there. So we usually, as Sajan said, if the patient is on subcutaneous infusion, continuous infusion, we give syringe drivers also. We set the medications into the syringe driver and connect the subcutaneous site and teach the caregivers how to stop the infusion, how to restart the infusion. All those trainings we give initially, and then we send back to the patient to home. So then our that home care teams will be doing the follow-up on that patient.
Okay, thank you very much, madam. And are you what are the emergencies? So, what are the special advices you should give if you are sending the patient to the home with this?
Could you please repeat the question?
If you are sending the patient with this to the home, what are the things you should especially teach to the patient regarding emergency? So, something like that. What you can expect?
What emergency you can expect from the subcutaneous infusion? What type?
Maybe edema, yeah,
So
irritation
mild
or
edema,
something.
definitely. Before insertion, if you decide subcutaneous infusion suitable for that patient, you have to give a adequate give a proper explanation to the patient and the caregivers that mild edema in around the site
Maybe
is
there.
normal.
Okay.
So that you have to done earlier also, and then so after putting the needle, what you can do is you can give some few initially few that they will experience pain, but gradually that pain will subside. And
Okay.
if accidentally the needle is removed, No problem. No, nothing worry about that. There is no way of bleeding and all. That is, the needle is in the subcutaneous site only. No. So if there is accidentally removed, no problem. They can discard the needle. That is it. That's it. So no other complications can occur these subcutaneous infusions patients.
Okay, thank you so much.
Yeah. Here we are practicing subcutaneous infusion only. Most of the patients, if there's some antibiotics and some of the medications we can't give subcutaneously, that time we prefer intravenous route. But we can, if you choose subcutaneous infusions, you can avoid multiple pricks. Okay, so after chemotherapy and radiotherapy, you won't get proper vein. So what you can do is you can give multiple pricks. No, that we can avoid. If you choose subcutaneous infusion, definitely we can avoid multiple pricks. So only one prick is needed for subcutaneous infusion. That is one of the biggest advantages of this subcutaneous infusion. Okay, and even home care settings also they can manage subcutaneous infusion. Any other doubts? Others? Today also we don't have a patient story. I expect one of you come with a patient story, but it didn't happen. So in palliative care settings, as Sajan said, the most of the medications which we can give subcutaneously, no need intravenous route, but here our main aim is to improve the quality of life through through proper symptom control. So symptom control is done by subcutaneous route. Usually in our inpatient settings, we use in subcutaneous infusions. So if you don't have any doubts, we can wind up the session. But before wind up the sessions, I would like to highlight few things. If the patient is having mild to moderate dehydration, we can choose that subcutaneous infusion. That's not a severe dehydration patients. You don't choose this route. This is the absorption is very low. So if the patient is having mild to moderate dehydrations, you can choose this method. And the advantages we already discussed. This is the low cost. It can not expect too much that infections or thrombophlebitis and all. So this is under subcutaneous. This is in the subcutaneous route, so we don't expect too many potential complications or infections. So this is the safest route for administrating injection site infusions. So thank you. We'll meet you again next week.